Okay,
Okay.
very specific title. I was charged with um, this task. Introduction. I'm John Guilfoose. I'm an infectious disease provider at WVU in Morgantown, West Virginia, at Ruby Memorial. I've been practicing for about 2 decades, a little bit over 2 decades. At WVU, the viral hepatologies tend to reside in the infectious disease clinic, whereas in other facilities it might be more in the hepatology clinics. It's all hit and miss from one facility to the next, but we tend to have the viral hepatitis be primarily seen in the infectious disease clinic here. And we're going to talk about what the issues are potentially in patients receiving oral HIV PrEP who have chronic hepatitis B. All right. Little may take this stuff, and then I have no disclosure. So what is the issue? Why does this even warrant a PowerPoint and a didactic? So basically, the gist of it is that individuals with chronic Hep B at risk for HIV may benefit from PrEP with tenofovir-based antiviral therapy, and I'll hopefully make that point over the next couple of slides, that there is some potential benefit to patients with chronic Hep B who might be at risk of HIV acquisition, that PrEP should be considered. The issue is that the active components of oral HIV PrEP also are active at inhibiting hepatitis B, both the tenofovir component and the FTC component. And so if you start somebody who has chronic Hep B on HIV PrEP under the guises of HIV PrEP, you are incidentally providing a de facto treatment for their hepatitis B. Now, that might sound like purely a good thing, and I can rationalize in some ways that is. In fact, it would lead to potentially better control and less long-term morbidity from the hepatitis B. So that's the good part. However, there's some potential downsides when we start talking about stopping PrEP. And so the hesitancy with oral PrEP with people with chronic Hep B comes from the fact that you can reactivate Hep B. And we'll talk about its natural history. We'll talk about the virology a little bit, about why that happens. But it's really during periods of antiviral cessation. So when would that happen? That would happen when we assess a patient, or a patient assesses themselves as no longer needing PrEP. If they have Hep B, the time period when you stop can be a concern. And we will say it's a theoretical concern, and I'll talk about the data that says whether or not it is actually a concern. Okay. And again, this talk, as mentioned in the title, is only referencing oral PrEP. The injectable agents, the lenacapavir and the integrase inhibitor cabotegravir-based drugs have no activity against hepatitis B, and so they don't count in this talk. So we're only talking about oral PrEP, the Truvada and Descovy, the tenofovir and 3TC containing regimens. Okay, so to set the context, hepatitis B is common, like common, much more common, magnitudinally so than in HIV. So we talk hundreds of millions of people having active chronic Hep B, okay? Or chronic Hep B is a better terminology, various forms. And the issue is most of these patients in PrEP trials were excluded. So if you just go by the books and you were to read the initial trials for PrEP patients, it excluded patients with Hep B because of that factor I talked about, okay? And excluding patients with Hep B excludes millions of potential opportunities to prevent HIV infection via PrEP. So and you can see the numbers up here, and yeah, so that's the issue. We don't want to necessarily avoid it. And when we talk about the hepatitis B virus, the transmission risk factors are incredibly similar to HIV. They really are similar. So it's again blood and body fluids that are the primary vehicles for transmission, and the activities that can lead to transmission can be drug use, sexual contact, and of course mother-to-child transmission. So really similar mechanisms of transmission. So if you had a patient who does have hepatitis B, there's a chance that they have at least some risk behavior for acquisition of HIV. So you can imagine if you're considering PrEP, it's probably a logical population to target as long as it's not the mother-to-child transmission part. That one doesn't make much sense. All right. And just know, remember, I showed this slide a second ago that has like different levels of prevalence in different parts around the world. And you can do some generic characterizations of transmission mechanisms based upon these prevalence areas. So if you go to the areas that are really highly endemic, most of that is not going to be from drug use or sexual transmission or other percutaneous or permucosal transmission. It's mostly going to be vertical transmission. That's mother-to-child transmission. And that's those really highly endemic areas, Southeast Asia, Sub-Saharan Africa, etc. In areas of more low endemicity, we don't talk about mother-to-child transmission being a primary risk factor. It tends to be more akin to risk factors for HIV transmission. So primarily horizontal transmission. So first and foremost, I think if you're evaluating a patient for HIV PrEP, one of the things we have to make sure we do is go ahead and check hepatitis B testing. And I mentioned this one because in certain case series, it's not 100% where people think to check for hepatitis B serologies at a time. And again, it makes sense to go ahead and check baseline hepatitis B serologies due to shared risk behavior, shared risk transmissions, number one. And of course, the whole pertinent part of this talk is there's some potential extra monitoring we're going to need to do. And then remember, if you ever assess a patient who doesn't have exposure to hepatitis B, it's an opportunity for vaccination. Unique for hepatitis B as opposed to HIV prevention is we have a very effective group of vaccines for Hep B, and more motivation to screen and assess and prevent when possible. The screening tests that you'd want to run are these three. You'd want to start off with the surface antigen. Generically speaking, probably people have nightmares remembering the old tables with the various time frames of surface antigen, E antigen, core, antibody, etc., that people can evaluate. But we can simplify it into really three main tests that we need to order on people to screen. And that's looking for active disease with surface antigen, immunity with surface antibody. And again, that immunity can be either from vaccine or natural exposure. So evidence of active disease with antigen, immunity with surface antibody, and then prior exposure with core. If your patient does have either surface antigen or core, you can consider additional testing. In other words, patients who have not developed surface antibody, you can further clarify the situation by looking at DNA as well as E antigens. Do remember that hepatitis D, which isn't really any part of this talk, is just one that we'd always want to think of if you found a positive surface antigen. Remember that hepatitis D is that weird defective virus that can be dependent upon active Hep B and can co-transmit. So we'd always want to screen for that if we actually do diagnose someone with active Hep B. All right, but getting back to the talk. So how are we doing, by the way, with hepatitis B vaccination? Answer is we've got a long way to go. I take this opportunity to talk about a vaccine preventable disease, and in this scenario, we have good vaccines for it, and you can see we have a long way to go to get catch up for U.S. adults. It's part of the routine childhood vaccination series these days, but really a lot of uncaught up adults. And remember, in terms of if you're looking at vaccines, what's new in the vaccine world for hepatitis B, for those who don't take care of the viral hepatitis as much, there is a new immune adjuvanted vaccine that allows you to really provide protection more quickly. And in some studies, a higher rate of seroconversion. So remember, the classic vaccinations are at first visit, a month follow-up, and then 6 months down the road. Whereas the new immune adjuvant vaccine, you can get somebody fully vaccinated after just the 1 month follow-up. So you can give it a baseline and then 1 month follow-up. So anyway, a bit of an aside, but wanted to touch on how important it is to vaccinate our patients for hepatitis B, so that hopefully this entire talk becomes impertinent if we get people protected. So again, to understand this whole issue, the issue with hepatitis B and why it can reactivate, why reactivation is potentially a concern, we have to go back and revisit the virus itself, the hepatitis B virus. It's different than HIV, and it's very different than the other viral hepatitis, such as hepatitis C, in that it's a DNA virus. And what does that mean to us functionally? It means that once you got it, you got it. A DNA virus becomes part of you as the host. It forms little microchromosomes in your hepatocytes. And as far as we know, we cannot make that go away. So it's there for a lifetime. Okay. And that's very different than our understanding of hepatitis C. With hepatitis C, we talk about curing people. We talk about treating people, curing them, and it's gone. With hepatitis B, we talk about either virologic control from the immune system or biologic control from medications, but very akin to HIV. If you stop medicines in those patients, you can have a return of the viremia. So it never really goes away. DNA viruses are there for life. Question to the group: Why can we use HIV medicines, the nucleoside reverse transcriptase inhibitors? Why can we use things that inhibit retroviruses for a DNA virus? Because it doesn't make sense. It's not something you could intuit or just rationalize. It comes down to a quirk of nature. Hepatitis B sort of breaks the paradigm or dogma of most beings or things, and whatever you want to call a virus, and it copies its own genomic material through an RNA intermediate, which is weird. Remember, most things will copy DNA to DNA or RNA back to DNA, like a retrovirus. But this one copies DNA to RNA, then back to DNA. And that is, we're lucky that it does that, because we can take advantage of that RNA to DNA reverse transcriptase activity and inhibit it with our reverse transcriptase inhibitors, so that the HIV medicines that work as false substrates to inhibit the reverse transcriptase enzyme have activity. So that's a beautiful thing. And that's also what's the whole gist of this talk. Although not directly related, I wanted to take one more moment, since we're talking about hepatitis B, to remind everybody what an aggressive and evil virus hepatitis B is. Hepatitis B, also unique amongst the viral hepatitis, in it is a truly oncogenic virus. So if we sort of step back and say, what are the truly oncogenic viruses out there? HPV, everybody knows HPV is very oncogenic, and we talk about giving the vaccine as a cancer vaccine, cancer prevention vaccine. We should probably think about hepatitis B vaccination as one more strategy of being a, quote, cancer vaccine. So hepatitis B is really very pro-oncogenic for hepatocellular carcinoma, much more so than, say, hepatitis C. So, because it actually has an oncogene that pushes the whole process forward. Okay. And for those who don't take care of hepatitis B, a lot of this will look familiar, but there should be a couple things that surprise you. So remember, chronic Hep B, as with any chronic hepatitis, can progressively lead to the laying down of scar tissue. And that scar tissue, when it becomes functionally important, is deemed cirrhosis. And the cirrhosis can be compensated or can decompensate, where it becomes life-threatening. And that cirrhosis and scar tissue can lead to cancer. And remember, with that oncogene present, what's unique with Hep B as opposed to hepatitis C is you can progress even without requisite cirrhosis due to the oncogene directly from chronic hepatitis to cancer. So you don't have to progress through F3, F4 fibrosis. You can go straight from having chronic Hep B to cancer. Also unique and different due to the fact that this is a DNA virus. So what we don't see for hepatitis C is the stuff over here on the right-hand side. This sort of inactive disease, flaring, going active, quiescent, reactivating. This whole concept of being a cult and then reactivating is a consequence of it being a DNA virus, a consequence of it never really going away, and part of the issue at play of why we have to be concerned when we treat people, or at least be careful when we treat people with oral PrEP. All right. So remember, just as we step back and we kind of talk about, why is this a big deal? Don't you want to treat everybody who has Chronic Hep B, the answer is no. Remember, during acute Hep B, you really don't want to do anything. So if you acquire acute hepatitis B as an adult, so I should have underlined this adult part. This is really as adult. If you acquire hepatitis B or exposed to hepatitis B as an adult, there's a 90 to 95% chance that you will develop immune control of that virus. You'll develop surface antibody protection with time. You might suffer through an acute viral hepatitis, but 90 to 95% of the time as an adult, you will win. You will develop good immune system control. Okay, there's no therapy required. That's just natural history. It'll happen. In fact, it's not really advocated you intervene in that scenario. Chronic hepatitis B, which is basically defined as someone who does not control that virus on their own in 6 months, does have treatment options. The treatment options are the ones I mentioned. They're the ones that inhibit that reverse transcriptase activity of this odd DNA to RNA to DNA polymerase that we have. And most of these drugs will look familiar to those on the call today because this is a PrEP talk, and tenofovir in both of its derivatives, both the TDF and the TAF, as well as lamivudine and emtricitabine, have activity against hepatitis B. The only one up there you probably aren't familiar with is entecavir. That's not a drug we use in HIV, but we use it isolated in hepatitis B. So anyway, the punchline is we have these treatments available, and the decision of who to treat is complicated. So as opposed to the paradigm right now for HIV, if you have someone who's HIV positive, you want to put them on treatment. If you have someone who's HCV positive, hepatitis C, you want to put them on treatment. The concept is treat everybody, treat them now. Get people the benefit of therapy, and from a public health standpoint, make them undetectable. Hepatitis B is not there yet. Hepatitis B has complicated treatment sort of decision tree, and that's part of the issue. So when you are contemplating putting a patient who has hepatitis B and you're contemplating putting them on PrEP, are you actually starting them on treatment in someone you otherwise would not? So what factors do we look at? And you don't need to know these. It's just I want you to be familiar with the concepts. We look at their e antigen status. So remember, the e antigen is sort of a nice qualitative evaluation of infectivity and activity of hepatitis B. We look at hepatitis B viral load, and we look at particular numbers. So as opposed to HIV and Hep C, where we don't hold people to certain criteria before treating them with regard to viral loads, we just treat them to try to get them to go away. With Hep B, the viral load matters, and there's a couple other things that we look at, including are they cirrhotic, are the e antigen positive or negative, what viral loads we need to count. And there's very complicated tables to look at. We also would like to only consider treating people when there's disease impact. So in other words, are their liver enzymes elevated? The people who derive benefit from Hep B treatment are really the ones that have some degree of itis involved, some degree of chronic hepatitis. So have some inflammation, some elevated liver enzymes. And remember those fibrosis assessments that we do for all the viral hepatitis, where it's on a 5-point scale. 0 through 4 is the F scores, 0 being no fibrosis and 4 being cirrhotic. We want to see that there's some degree of scar tissue being laid down in these patients, F2 or greater, to really consider them for treatment in a lot of scenarios. So in other words, you don't have to know this. I know this is not a talk on who gets treated for Hep B, but you sort of need to know that because we might inadvertently be committing people to treatment. So treatment decisions on who to treat are complicated. And then this is the part where we really don't know how long to treat people. So in general, when I see a patient who's going to get started on hepatitis B treatment, I prepare them for lifelong therapy. And I say, man, you're going to be on this treatment. I will follow you up routinely about every 6 months and do lab tests and look at your immunologic profiles, your E antibody, E antigen, and your surface antibody and surface antigen. In some people, if you develop a certain pattern, you can consider stopping therapy. But most of my patients, I can't. Most people are sort of committed to treatment and have to stay on it. Okay. So when you're committing somebody to hepatitis B therapy, it's often long-term. And that's a little bit different than the conversations that you have with PrEP patients. So if you're having a patient that you're committing to PrEP, it might be just while they have certain risk behaviors. But if they have concomitant Hep B and you're de facto starting Hep B therapy, there'll be some concern when you go to stop. And that's what we'll talk more about at this point. So getting back to that PrEP Hep B. Yeah, so the issue is the Hep B will receive this bystander treatment when using HIV PrEP, oral PrEP. So what's the big deal? Because for some patients, we will therefore be initiating treatment when it otherwise would not be indicated. So a lot of these patients won't have elevated liver enzymes. They won't have an elevated viral load. They won't have F2 or greater fibrosis. So while initiating TAF and emtricitabine or TDF and emtricitabine, we are starting them on treatment and where they otherwise wouldn't have met criteria. Not necessarily a bad thing, but not necessarily also benefiting them, at least from the hepatitis B standpoint. And often people are not committed to lifelong.
She's been given so many smiles and talking.
Nope, that was someone else on the call. But yeah, that's kind of the issue. And then that virology, that concept I talked about this being a DNA virus, how does that play into this? It directly comes back to the fact that hepatitis B virus reactivates and flares under certain settings. And one of those settings I'll talk about in the further slide is when we actually stop treatment. So what is a hepatitis B reactivation and flare? Reactivation we define as a DNA level that goes up. So say someone's viral load was really low and it suddenly goes 2 times elevated. So say it was a couple hundred and it goes to a few thousand to tens of thousands. That would be considered reactivation. Flare is more the itis evaluation. It's when the liver enzymes elevate to multiple times what they were at baseline. A flare is most dangerous if your liver is already teetering on compensation. And so a hepatitis B flare can be annoying and symptomatic to the degree of almost like an acute viral hepatitis, but self-limited in somebody without chronic liver disease, without significant fibrosis. However, if you're a compensated cirrhotic and you undergo a flare, hepatitis B flare, it can kill you. And I enter into evidence the hepatitis C treatment drugs. So when do these flares occur? Do you remember, if anybody's on this call has ever treated someone with hepatitis C, Epclusa, Harvoni, Zepatier, Mavorite, any of the drugs, they all carry a black box warning. And they say, hey, be careful in chronic Hep B patients. In chronic Hep B patients, if you treat their Hep C, it can induce a flare. Hep B can flare. And that hepatitis B flare can be dangerous if your patient already is borderline compensated with regard to their chronic liver disease. So in other words, if you're a compensated cirrhotic, they can be pushed over the edge. So we know that. That's black box warnings on the Hep C drugs. When other times can you see flares? Well, we in medicine can do it to people when we suppress people's immune system. So give somebody steroids, chemotherapy, rituximab, anti-CD20 agents, a lot of the TNF agents, etc. We can induce flares by sort of suppressing the immune system. But one of the weirder things that can happen is just stopping hepatitis B therapy. When you stop treatment, you have to watch patients and make sure you don't induce a flare. It's called a cessation of treatment flare. And that can become a really almost expected scenario in PrEP, because you're likely not committing someone to lifelong treatment. Okay, so when I do see people with Hep B, I really double and triple down on adherence counseling because of this weird flare concept. So remember, if you see someone and they don't take their HIV medicines, it doesn't mean they're going to flare and suddenly get sicker. If they don't take their hepatitis C medicines, it's just not going to work. If they don't take their PrEP medicines, it's not going to work. But if they stop taking their Hep B therapy, they can experience harm, potentially. And I'll talk about the numbers involved. It's not high, but it can happen. Okay. Is all the concern warranted? So this is a giant amalgam of clinical trials that says if you take all patients with hepatitis B and you look at trials where treatment was stopped for one reason or another, what happens? What happens? Let's look at the clinical outcomes. And these are not PrEP patients because these studies don't exist. There just haven't been enough giant studies where people have concomitant hepatitis B and PrEP. Again, most of those patients were excluded from clinical trials. But if we take all patients with hepatitis B on antiviral therapy, where the antiviral therapy is stopped, what happens to these patients? What do these hepatitis B flares look like? They happen. The punchline is they happen. So those reactivations happen in the majority. So 63 to 83% of patients, so the majority of patients will actually experience DNA reactivation. Clinical flares, so it's in other words, seeing the transaminases elevate to 3 to 5 times normal, happen in a third of the time. And And this is the dread one, and really why they were excluded from trials is not that common. So thank goodness the acute liver failure and potential death is actually less than 1%. So I think this is if you wanted a take home message of what's the likelihood of PrEP cessation causing a hepatitis B flare, the answer is there. It's less than 1%. Can you see it, or I should say, causing liver failure? So you could cause a flare, but what's the functional consequence? Will your patient potentially experience a life-threatening manifestation? The answer is potentially, but incredibly low. Incredibly low. So relatively safe. This is a 2022 study, so pretty new data. And if you remember, the major PrEP trials were from the early 2000 aughts, so 2010 to 12 was when we got the approvals and stuff like that. So this trial is newer than most of the hepatitis. I'm sorry, most of the HIV PrEP trials. So their overall recommendations for someone who you're considering giving HIV PrEP to who has concomitant chronic Hep B, double down on that adherence counseling. So we always obviously try to do adherence counseling on patients who we're going to give PrEP to, because it only works if you take it. We have ample clinical studies that show that and logic that says that. But because that extra stressor of the potential cessation flare, we double down on adherence therapies. We should make sure that we have close follow-up from a laboratory and clinical standpoint, and do some extra clinical monitoring. So we all know that PrEP patients get routine STI testing and routine HIV testing. But we want to include in this some liver enzyme testing as well as directed hepatitis B evaluations. And again, the most important ones would be the DNA evaluation. Because of this dual potential for efficacy, we want to probably tell people that they're may be on PrEP or some hepatitis B therapy for a long time and prepare them for that. So prepare them for the fact that we might, in fact, have to restart hepatitis B therapy, even if they wanted to stop PrEP, or continue the hepatitis B therapy, even if they wanted to stop PrEP, especially if they experience reactivation. And if you do have somebody who you decide to stop PrEP on, who doesn't otherwise meet criteria for hepatitis B, just watch them carefully. Watch them at 3 months, 6 months, probably even a year out, just to make sure they don't reactivate because of the numbers involved. More details
Dr.
for
Guilfoose,
yeah.
sorry, you have a question. It says, how often should the DNA testing be done?
Yeah, probably whenever you're doing if you have a hepatitis B patient, when you're doing your HIV test. So you're going to do your HIV testing every 3 months. It would make sense to me to throw that hepatitis B DNA test in there as well. Make sure you don't have reactivation. And again, with routine PrEP monitoring, there is no recommendations for LFT monitoring. And I rechecked this to make sure that liver enzymes weren't advocated to be screened, and they're not part of routine PrEP. And I would say if you have a Hep B co-infected patient, you would want to do that. You would want to add that in somewhere in the 3 to 6 month zone. When I'm treating people for Hep B, I monitor usually their liver enzymes and their DNA every 6 months to ensure efficacy. If I'm unsure of adherence or if I'm stopping somebody, I check it more often. Okay. So yeah, I would throw that. So great question and super pertinent to this slide right here. So we kind of got it answered. I'd throw that stuff on there. And then remember one other part. Remember that quirky extra gene that hepatitis B carries with it. And just remember, if you do have a patient who has chronic Hep B, see if they qualify for hepatocellular carcinoma screening with reticuloquadrant ultrasounds. Since they're in your care for HIV PrEP, take advantage of that fact that you might be able to engage in some other preventative health. Remember, not everybody with chronic Hep B requires HCC screening. That's a whole nother talk. I don't want to waste your all's time from that perspective, but just know there's certain variables that go into who requires Q6 month ultrasound screening. It tends to have an age variable. It has an F-score variable, so in other words, how much scar tissue they have, and also an ethnicity variable. So it tends to, the males with more fibrosis and an African descent require screening much more early than others. So there's a lot of variables you need to look at to understand what your HCC screening is, but just wanted to throw that in there. If you're already seeing these patients routinely, you might want to take over their HCC screening. Okay, Now, honestly, when I first read about on-demand PrEP in patients with chronic Hep B, I really kind of favored the red up there. I was like, man, that's a terrible idea. The whole gist of this talk is that treatment cessations are risky. And what is on-demand PrEP on-demand PrEP, but permitted or advocated less than perfect adherence, right? You're advocating somebody take medications just when needed and by default, therefore not taking it every day. So the initial thought I would have with on-demand PrEP is it's probably not a good idea. Thankfully, there have been some studies that said it actually is okay. So when can on-demand PrEP be offered? On-demand PrEP be offered for patients with Hep B co-infection? You have to make sure two things. Number one, you have to make sure that they don't have cirrhosis of the liver to begin with, because remember, the reactivation is really most dangerous in somebody who's cirrhotic. And so you have to be really confident that you clinically know how to evaluate people for cirrhosis. Remember, that's often not just as easy as asking on history or physical exam. In fact, I miss most people who are cirrhotic on physical exam. It requires elastography-based testing and some lab work to make sure the fibrosis scores aren't high, et cetera. So you really want to make sure your patient's not cirrhotic and doesn't meet any other criteria for Hep B. So obviously, if you have somebody who meets criteria for Hep B therapy, say the liver enzymes are high, they have F2 fibrosis, and their viral load is high, you don't want to offer them intermittent PrEP. You want to say, you know what, I'm going to treat your Hep B and offer you HIV PrEP at the same time. So you'd have to have a non-cirrhotic who doesn't otherwise need therapy to ever offer them on-demand PrEP. And again, just the converse of that is, when can you never offer somebody on-demand PrEP with Hep B co-infection? And that's if they're cirrhotic, because you're potentially going to lead to reactivation of disease, and those are the situations where a flare can be dangerous or deadly. And obviously, you wouldn't offer on-demand PrEP if your patient actually required Hep B therapy. Theoretical risk, I couldn't find any evidence for this being true, but it's written about as a theoretical concept, is also on-demand PrEP. You're offering these low levels of antiviral medications, and there's some concern that patients might develop resistance to the hepatitis B from the hepatitis B standpoint. Although that's more, I guess, a theoretical risk. I will say, of the two medicines in oral PrEP, it's the 3TC that more rapidly becomes resistant. Tenofovir resistance is rare, but it still is a theoretical concept of concern. So what about injectable PrEP? Again, it's not an issue. Injectable PrEP doesn't have activity against hepatitis B, so this whole talk is impertinent and doesn't matter. So some providers preferentially go towards injectable PrEP if you have a hepatitis B co-infected patient, and that's fine. Then none of this matters. But just know that you will not derive the benefit of hepatitis B therapy. So if you had a patient who is considering PrEP and they meet criteria for Hep B therapy, do the oral PrEP. That's the way to go, because then you're getting the 2 for 1. Okay. This is a bit of a controversial slide because I wouldn't advocate it, but it works. So this is, what about PrEP as a hepatitis B prevention? So remember, this is not an FDA approval. We use HIV PrEP to prevent HIV. But does it have, if you think about it, it's got 2 active antivirals against hepatitis B. Does it work? Does it prevent hepatitis B acquisition? And it does. It turns out that it works. So why it's not really probably talked about and why we don't specifically use it for hepatitis B prevention is because we got a vaccine. So we already have a vaccine, but it does work. It's just sort of one of those things where people ask that question on occasion, and the answer is yes. The data behind it is kind of down here. It actually significant. So if we look at this large cohort and people not on PrEP, who this was a study population at risk for hepatitis B acquisition, and people who are not on PrEP, you can see had a significant incidence of hepatitis B acquisition, which is a bummer. It means we didn't vaccinate well. But in those who took PrEP or even on-demand PrEP, had really low, much less statistically significant decrease incidence of hepatitis B acquisition. So kind of cool. Although again, I advocate vaccination as your primary prevention strategy. So summary is just that stuff up here, and I'll open it up for any questions that you all may have. Besides the already very good question on how frequently to monitor. By the way, there's no guidelines on that. That's just clinical. It's my opinion from having taken care of a lot of these patients.